For me, the elotoscopy is failed or scarred. This year, or in both, is vice versa. It's like a in a coin, two sides of a one coin. Once there is a fail, there is a sources of scarred, or once there is a, those are patients are prone for scarred. Those patients are actually may land up with a failed cases. The second attempt, always in such all those cases, they need a second attempt after a failure discharge. So need a more meticulous workup and more skill. So what we can do, but as we always knows that prevention is always better than any other action or cure. So just before start, I want to say that revision discharge situation can be avoided by proper assessment and preoperative preparation of our patients. By using operative microscope, we can revise scar, we can use a silastic intubation and intraoperative care. I will say in my next cases. So those are the patients actually. Those are the patients in such patient may land up with scar or failure. So is a huge swelling, is a lacrimal sac, need abscess drainage earlier, or you can go for an endoscopic also. Whatever way, this is the point. But, and not only that, our previous surgeons mentioned each and every point regarding preoperative evaluation, SEC, etc., the canalicular system, but the phase and periorbita also plays a one important role, and the position of the punctum, health of the canaliculus, and as a whole lead. Is there any laxity or medial canton tendon laxity? So before revision DCR, if there's a recurrent cases, failed cases, we can drain it out the pass like this. We can drain it out the simply one stab incision, and we can send the pass for culture and sensitivity. This is, it will give a lots of information to us to avoid the scar in our subsequent treatment. So those are the patients, and in the recurrent cases, so, and why? Why? Then in my next slide, we'll see that in such cases, it was treated earlier by different antibiotics, but only and Vanco and Imica is sensitive in such cases. So there are a few, it may be a Staphylococcus also, but it may be a Pseudomonas. Those are the organism. Those need a only one or two antibiotic may be left alone for left for you to treat, and ultimately it may land up with so many issues like there may be a scar on canalicular system, or there may be a proximal canalicular, it may be distal. So once we want to, before start, we will evaluate all those points at what level there is obstruction. It is only NLDO, or in common canalicular system, or pre-existing. Role of CT scan and others are very limited. For some, in some cases, for research purpose, or some in sophisticated, if we want, then we can go for a computerized digital subtraction dactylocystograph. This is by with the help of a type of a CT scan, specialized, we can inject with a cannula, or we can just in the cul-de-sac, we can just some dye, radio frequency dye, and then we can press and track this thing and at what level there is obstruction. I again want to highlight few points like, so that is our evaluation kit. Whatever, it may be a primary, or it may be a scar prone, or it may be maybe a revision cases. We want to evaluate all the level of obstruction, the number of obstruction, and the other condition. Is there any scarred thing, or is there any other pathology? And the nose, we want to see the nose also, the by nasal endoscope. This is very important to do a nasal endoscope or your ENT colleague. Otherwise, it may be difficult. So, and may need some radiological investigation in some cases where there is a you can suspect some tumor, etc. There may be obstruction at the membrane, It may be one of the culprits. So we may undergo in such cases by endoscopic revision. It is very, very difficult. So, but we can do, or sometimes in a expert hand, it can be done by endoscopic also. By external, I will prefer generally external. So we can remove, and I will just highlight those some my videos. What are the points we want to see all those points. And in case of a revision, there is a big question is at what time we will go for revision. In that early postoperative assessment, we can think if there is a blockage or there is a scar or there is a recurring infection, then we can go for as early as go for within 2 weeks, we can go endoscopy. But in some cases, if we want to do external approach, we should wait for at least for 3 months for revision with stylistic intubation. Those are my protocols in such cases. So as I already highlighted that we should do a under endoscopic thing, under the microscope, and in such a huge sac. If it is a huge sac, then there is a definitely it will be difficult because after a lacrimal abscess, and with everyone we are experienced with an external scar, or there is some on the soft tissue, but there may be there is a membrane or scar in the at the level of common canalicular junction, common canalicular sac junctions. I am highlighting here this patient. So once I open the sac, you just minutely observe there is some membranous structure. It is that color is little different, and there is a membrane all around the inside the sac. Those are land up with, if we don't remove those membrane, it may land up with some it may I just want to highlight. So moment to introduce the probe, and there is this is the membrane. So that is excision of the membrane is one of the step to avoid further failure. Earlier in this patient, it was failed because of there's a thick membrane. Then there's two options in your hand. One is that we can do a silastic intubation, or you can go for a mitomycin C also. So as Dr. Neelanda, this is the silastic tube rider. So instead of forceps, we can use smoothly. We can just like a 10-0 Vicryl for our we are using for in a sulcus fixator lens. The same like we can glider with the help of the silastic tube glider. We can engage in the tip of the glider and etc. There is a very less time for us. So in a scar-prone condition, we can use a mitomycin C. And those are the endoscopy is one of the important steps in such cases. We can evaluate endoscopy, and there is no such time for us. So I want to say for a meticulous excision, meticulous dissection, and everything we can do. Thank you.